Good afternoon, everyone, and thanks for joining today's webinar, The Whole Family Approach, How TANF Programs Can Engage Customers in Mental Health Services. We are delighted to have a great group of expert presenters to discuss this topic with you today. I'm James Butler, and I serve as one of the Family Assistance Program Specialists here at the Office of Family Assistance within the Administration for Children and Families. For anyone who might not be as familiar with the webinar platform that we're using today, I'd like to just quickly give you a brief tour of the platform before introducing today's facilitator. So I wanted to review just how you can submit your questions using the Zoom webinar platform, since all of the participants will be muted. You'll see at the bottom of your screen a Q&A icon. If you click that icon, it will generate a question and answer box where you can type in your question or questions. You can note that your question, will not be visible until they are answered, but feel free to submit as many questions as you like at any time throughout the webinar. And if you need to indicate a specific speaker that you'd like to respond to your question, please do that as well. And we will monitor your questions and address them during our Q&A session. We're also going to launch several polls during today's webinar that will pop up on your screen automatically. And also it will include an evaluation poll that will pop up at the end of the webinar, which I'll remind you again as we close out. You can respond to the polls by clicking on the radio button next to your preferred response. And we're going to leave each poll open for about maybe 30 seconds. So now what I'd like to do is hand things over to our facilitator, who most of you may already be familiar with, Mary Roberto, who serves as a project director at ICF International. Mary?
Thank you, James. Hi, everyone. As James said, my name is Mary Roberto, and I work at ICF in some of the areas that we'll be talking about today. I'm honored to serve as a facilitator for this important discussion about the intersections between trauma, poverty, and mental health, including information on whole family approaches to engaging TANF customers in mental health services. These issues live close to my heart, as I'm sure they do for you too. As some of you are probably aware, January is National Poverty in America Awareness Month. The American Heritage Dictionary defines the state of being poor as having insufficient wealth in life in a manner considered acceptable in a society. According to the federal government, 88.4% of people in the US achieved an acceptable standard of living in 2021. Right now, the ink is barely dry on the 2023 federal poverty guidelines, but they already seem a bit antiquated, especially in light of the cost of living and things of that nature right now. So 24,860 for a 3-person household. The Johnson administration's first crack at household was 3,000 per family, and that was 60 years ago. Also, while working with TANF families, many of you have observed the growing set of challenges to their mental well-being as a result of the COVID-19 pandemic. And this has been amplified with rising costs of just daily needs and expenses such as food, transportation, heating and cooling costs, and housing. Difficulties with finding quality and long-term employment, and challenges with access to healthcare. These and other issues around childcare availability and school routines for children that have been appended during the pandemic continue to place an increased stress and significant burden on low-income families. So thankfully, TANF programs can provide important touch points to low-income families facing challenges like these by understanding and improving access to mental health for all family members, parents, caregivers, and children. Today, thankfully, thanks to all of you incredible speakers that will be explaining the intersection between poverty, trauma, and mental health, and share strategies that can help improve the long-term mental health outcomes for low-income families. All of you will be able to engage with the speakers and have a dialogue with them through the Q&A, as James mentioned earlier, to share strategies and think about this a little bit more deeply than maybe we do on a day-to-day. Next slide, please. And I'm going to go ahead and introduce our speakers. The first one is Dr. Mary Beth Vogel-Ferguson, a research associate at the research associate professor at the University of Utah, and Dr. Maria Aguilar Mendoza, an executive director from the Soboba Tribal TANF program, Arnold Ontiveros, a staff manager at the New Mexico Department of Human Services. Love the balloons behind your backdrop that we'll probably see in a minute, Arnold. Melissa Montano, OPRE Program Manager, New Mexico Department of Human Services, and Lisa Gutko, the Integrated Program Manager for FAST in Ramsey County, Minnesota. So thank you all. And the more in-depth bios are available to you to download. Next slide, please. We're going to start off with a poll, and the poll question is, which statement, which of the following statements do you believe is not true? 1 in 5 U.S. adults experience mental illness each year. 1 in 20 U.S. adults experience serious mental illness each year. 1 in 6 U.S. youth age 6 to 17 experience mental health disorder each year. 50% of all lifetime mental illness begins at age 14 and 75% by age 24. And suicide is the 10th leading cause of death among people ages 10 through 14 and 24 through 35. So again, which do you believe is not true? So most of you said that you don't believe that suicide is the 10th leading cause of death among individuals that are younger, the younger age group. Second is the 1 in 20 U.S. adults experience serious mental illness. So the answer is that suicide is the second leading cause of death among people aged 10 to 14 and 24 to 35. So there you have it. Very sad, but true news about that. And I guess we'll just move on now to you, Mary Beth. Why don't you go ahead and take the stage and get us going.
Okay, thank you, Mary. I'm really grateful for the opportunity to be here and just share some thoughts to open this session focusing on the whole family approach. Next. What I want to share today comes as a product of a funding relationship between Utah's Department of Workforce Services and our Social Research Institute at the University of Utah. In my work as a third-party evaluator for Utah's DWS, a primary part of my work has involved interviewing TANF recipients and using the client data to inform policy and develop new programs. The question of the relationship between poverty and other social issues, including mental health, has come up repeatedly. Most recently in Utah with the passing of the Intergenerational Poverty Mitigation Act, leading to questions about the relationship between poverty, mental health, and trauma. But to start with, I'd like to do, as Mary did, kind of clarify some terminology as I see it. Next. In my years of interviewing TANF recipients, I've certainly learned that poverty and mental health issues are not synonymous. Next. Poverty, by definition, similar to what Mary said, is the state of being extremely poor. And I would suggest for our context, being extremely poor in terms of financial resources. Next. According to the CDC, mental health focuses on our emotional, psychological, and social well-being. It affects how we think, feel, and act. And it's important to distinguish mental health from mental illness, as you really can't have one without the other. Much of the research on the relationship between these two issues starts with people living in poverty and explores differences when they have access to financial resources, even going so far as identifying a causal relationship. Next. However, I would suggest that it is more complicated than this, and that what we have is really a bit of which came first, the chicken or the egg kind of question. While not answering the question, most people recognize there's at least a bidirectional relationship between poverty and mental health issues. Living in poverty can cause mental health problems, just as mental health problems can lead to living in poverty. Next. So, current research has clearly shown that infusions of cash into the hands of poor families can reduce mental health issues. It's less clear if the mental health issue is really addressed or simply made less prominent for a short time due to the influx of cash. Providing more than just cash assistance, things like building skills, addressing social determinants of health, and asset building have been found to be more effective in improving mental health. Exposure to toxic stress, that is longer-term, repeated, high-dose stress, especially when experienced by children, can have a greater overall effect on individual functioning. Questions about childhood exposure to adversity and toxic stress as a precursor and potential contributor to adult challenges are seldom included in explorations of the relationship between poverty and mental health. Next. To that end, I'm going to take a few minutes to share data from our study with 1,001 TANF recipients in Utah. These were individuals relatively new to cash assistance who were required to participate in specific activities. These in-person interviews were conducted by myself and my staff in 2018 and 2019, actually finishing 2 weeks before the pandemic hit and everything shut down. Our earlier studies showed high rates of mental health and physical health issues, several types of child abuse, domestic violence, and other relationship issues. So for this new set of interviews, we added a set of questions introduced in the Adverse Childhood Experiences study. Next. For those unfamiliar with the ACEs study, just briefly, this study was conducted in the late 1990s in a hospital setting in Southern California among a generally middle and upper class population. The study asked patients a set of 10 to 12 questions, as you can see here, and used the data to explore the relationship between adverse experiences in childhood and many different adult outcomes. The ACE questions are not a validated measure and not for use in predicting outcomes for individuals, but it is a really valuable tool for learning about a population as a whole. Next. So some major findings of the ACEs study note that first, ACEs are common. Almost 2/3 of the study participants reported at least one ACE, and more than 1 in 5 reported 3 or more ACEs. ACE categories are interrelated. So if a respondent had one ACE, the probability of having more than one ACE went up to, on average, 80%. Accumulation of ACEs matters, so the higher the ACE score, the higher the risk. And ACEs are a powerful determinant of health. There is a strong dose-response relationship between ACE exposure and health risk, which means that as a person's ACE score increased, reflecting more childhood adversity, so did their risk of a variety of health and mental health problems. Next. This graph gives examples of how ACE data reflects the dose-response relationship. In each case, as you move from left to right, from 0 to 4 or more ACEs, you can see the increase in the prevalence of mood disorders, anxiety disorders, substance abuse, and impulse control disorders. Next. A similar pattern was found in working with work performance related measures, absenteeism, financial problems, and job problems. The higher the ACEs, the greater the prevalence of the issue. Next. So in 2018, our Department of Health added the ACEs questions to Utah's version of the Behavioral Risk Factor Surveillance System, or the BRFIS study. Next. Our Utah data is actually very similar to that found in the original ACEs study, with 40% reporting no ACEs, 44% 1 to 3, and just 16% reporting 4 or more ACEs. We were then able to compare the data to our TANF sample. Next. As you can see, the results for our TANF participants are very different, with only 10% reporting 0, 29% reporting 1 to 3, and 61% reporting 4 or more. As I look at the data, sometimes I wonder, you know, when you see a small child on the news, someone who's experienced abuse or neglect or any other kind of issues that were raised by those questions, we pour all sorts of resources into helping the child. But when that same person becomes a 23-year-old struggling welfare mom, as a society, I would suggest that we don't always have the same response. So my question always is then, what day did it change? What day did she change from stop being a victimized child and started being something else? This ACE data led us to wonder, how are the ACE scores of the TANF sample related to factors that impact success in TANF programs? Next. So we analyzed the ACEs data relative to multiple factors which have been associated with success in employment, both factors that support employment and factors that can make employment more challenging. We'll look at some of these areas, starting with learning issues. Next. So as you see here, we asked people about whether or not they were diagnosed with a learning disability as a child, whether they had been in special ed or resource classes, or if learning disabilities had been a work barrier. Across the board, you can see that same dose response. The higher the ACEs, the more likely someone has had these challenges growing up. Next. Continuing with education, we asked people about parental involvement in education, about their parents' level of education, and about their own ability to have gotten a high school diploma or GED. Again, across the board, the higher the ACEs, the more prevalent the challenge that had been in that person's life. Next. We asked global questions about people's experience of their own mental health and physical health, how they would rate it, excellent, very good, good, fair, or poor. The higher the ACEs, the more likely individuals were to rate their health or mental health as physical, as fair, or poor. Next. When we look at some specific mental health issues, we used validated screen measures for PTSD, anxiety, and depression. Again, as we look across the board, the prevalence of these issues goes up as the ACEs increase. And as you can see, even the prevalence of these issues overall is much higher than we find in the general population. Next. And then looking at some issues like social supports, criminal record, a partner preventing someone going to work, domestic violence, adult homelessness, all of these issues, the higher the prevalence of this challenge, the higher the ACEs. Next. And even when we look at things like family background, growing up in a two-parent home, having a welfare history, being a teen mom themselves, or being homeless as a child, the higher the ACEs, the more likely these challenges have been part of their experience. So as we look at the summary of some of these findings, we recognize that the prevalence of ACEs among the TANF populations is significantly higher than that in the general population. ACE scores are highly correlated to many of the factors that make work and other activities of adult living more difficult, including mental health issues. You know, we also learned that TANF recipients with high ACE scores are actually engaged in work and work activities at the same rate as other TANF recipients, but they were working fewer hours and making less in their wages. So this lower level of benefit from employment increases the likelihood that they'll remain in poverty longer. Next. I don't know about you, but this data can be really discouraging. But ACEs are not really a diagnosis or a label that we can put on a person. They can't tell us everything about an individual or determine what they need. As one case manager told us, just because I know an ACE history doesn't mean I know anything about a person's ability to work. For that reason, when we're implementing the information with ACEs into case management, we're not really interested in gathering scores, but more learning to be alert to what else might be impacting the person's ability to engage, including mental health. So how can we have what we learned here be useful? Next. First of all, it helps us make sense of some of the high levels of physical health and mental health issues reported among TANF recipients, rather than just thinking these are excuses to get out of working. The impacts of toxic stress are real. As the cartoon says, survival mode is supposed to be a phase that helps you save your life. It's not meant to be how you live. Next. Employers talk about needing workers with soft skills. But you know, many of the skills that they are looking for are learned in the parts of the brain that can be underdeveloped due to toxic stress. Missing appointments, rigidity, lack of goals can be labeled as laziness, disinterest, irresponsibility. But it could be that the person's brain was too busy living in survival mode to have the opportunity to develop these skills completely. I remember interviewing a young woman in central Utah, and she said, you know, I have no problem finding a job. I can get any job I apply for. I interview great, but I can't keep jobs because I have no idea how to get myself and my son out the door and where we need to be on time. She was literally baffled. She couldn't manage time in the way that she saw other people doing. She wanted help with that. These skills are key to employment, relationships, parenting. Next. And as we talk about the whole family approach, we recognize that the challenges created in childhood diversity, including mental health issues, can follow a person from childhood into adolescence and into adult life, and can be passed on to the next generation if they're not addressed through supporting individuals in developing their own capacities in these areas. Next. So where to start? These findings suggest that training on ACEs and childhood adversity could be very helpful in better understanding customer strengths and challenges and how to recognize and address possible gaps. Case plans could include options for addressing these issues, and these efforts really need to count. Attention to possible impacts of ACEs is key to long-term success, actually supporting moving families out of poverty. Because the blame and shame associated with ACEs and other traumatic experiences can make it really hard to ask for help and to receive the help to improve life for the next generation. But knowledge is a powerful tool for change. A review of broader TANF policy in light of this connection between early life adversity and success in moving out of poverty could be a real game changer for many program participants. And finally, next. Here is the ACE data again with one more group included. The green bars are data from agency staff. While their ACE scores are not as high as their clients, they are much higher than the general population. Supporting agency staff as they work with clients will be really important for their own success and the success of our programs. Next. So thank you so much for your time and interest in this important topic, and we look forward to hearing from people with boots on the ground.
Gosh, thank you, Mary Beth. That's a lot of information and good information, and I think maybe a lot of us have more questions than we have answers with all of that data. But yeah, it's great when you're talking about knowledge is key, and where we were even 10 years ago without information on brain functioning and toxic stress and all of how that impacts daily routines and functioning of all of us, but especially those that we're trying to help and the staff that are trying to do that work. So thank you so much for all the information. We're going to move on to our second poll question. How knowledgeable do you feel about resources available to address mental health needs of TANF participants in your program or community? So very comfortable, somewhat comfortable, neutral, somewhat uncomfortable. Or very knowledgeable, somewhat knowledgeable. Thanks, Jonna. And I see what you put in the chat about it's not that I don't know what's available. It's the availability doesn't seem to meet the need, which is just a great comment and very true in many communities, even with the influx of assistance in this area. It just doesn't seem like it is meeting the mark sometimes related to the need out there. So most of you say that you're somewhat comfortable, and second is kind of neutral. So hopefully with the remaining presentations and some other information that we can give you along the way, you'll hopefully have more resources and tools in your toolbox for this. We'll go ahead and move on to our next presenter. Go ahead, Maria.
Good morning, everyone. My name is Maria Aguirre Mendoza, and I am the Executive Director for the Saboba Tribal TANF program. Today, I will be sharing with you how our program engages customers in mental health services. So if we can go to the next slide. Historically, since the inception of our program in 2005, we have been incorporating mental health into our case management processes. It is provided to our families on an ongoing basis as needed. We have found that therapy can be used as a best practice to help identify a participant's best path to self-sufficiency. Ultimately, therapy allows for barriers to be identified. We contract with a marriage and family therapist who provides weekly sessions at all of our sites, provides classes and workshops that are accepted by the courts, and include parenting, anger management, substance abuse, and domestic violence. Over the years, our therapist has also stepped in to ensure our participation in our children's IEPs at school, and just that they're getting, the necessary school resources that are available to them. A lot of times, it costs a lot of money for schools to provide an IEP, so they're not very willing to give an individualized educational plan for the kids. And our therapist has stepped in over time to make sure that those things do happen. So if we can go ahead and move on to the next slide. So as part of our case management process, we require participants to attend at least one mental health therapy appointment. Based on preference, a client can attend at any of our 4 offices at their home or our practitioner's office. Our therapist provides quick response times for high-risk situations, and during the pandemic, she's also started providing telehealth appointments. Other components of our case management process include a vocational career assessment where we can identify where a participant is educational-wise, and also what work experience they have, and then what are their interests, which we take inventory assessments to identify a potential career path. A drug counseling assessment may also be required if the participant tested positive for an illegal substance during the application process. So something that our program does is we do require a drug test during the application process, and if they do test positive, they will be required upon approval of their TANF cash aid case to comply with the drug assessment. And then another component that I don't have listed here is classes. So we provide on-site parenting, baby and me, bonding, couples, and talking circles. And the workshops help the participants to get comfortable with the therapist and the idea of counseling. Our mental health therapist is certified and trained in equine and animal assist therapy, which is the use of horses in therapy, play therapy, which is used especially for mental health and emotional issues. EMDR, which is eye movement desensitization and reprocessing, which is widely used for treating trauma and promoting healing. Neurofeedback, which is especially good for helping with anxiety and attention deficit disorders. And then she also incorporates the Gottman's couples work, which is a therapy approach committed to understanding and building longevity in relationships. So if we can move on to the next slide. So the benefits to our clients is that mandatory counseling will be added to their work plan. They can get a work participation hour for their attendance in a session. We do require for them to at least attend one session and then more as needed or recommended. It helps us identify their barriers and guides their self-sufficiency path. And it's a foundation for their case management referrals. So for instance, if they need to be referred out for DV, substance abuse, parenting classes, marriage counseling, etc., it really helps us provide that as a wraparound service. And then increased privacy. So we cater to their comfort level. A lot of clients in the past have been reluctant to attend counseling sessions like with our local Indian health agencies just because it's less private for them. They may have a lot of relatives working there. It's a small community and there's a stigma about seeing a therapist. And then also too, if you're walking down one hallway, everybody knows where you're going. So it kind of stigmatizes the experience for them. And then on that note, we also built counseling into our incentives requirements. So if they're trying to get the marriage incentive, they're required to attend post and premarital counseling. And then to qualify for our baby exemption, with a baby under 1, they must attend Baby and Me workshops at least one time a month. And at those workshops, they get to learn about infant and early childhood development, infant safety. And we've also provided infant CPR and first aid classes in the past. So if we can move on to the next slide. So adding this component to our program is a wake-up call for our participants. A lot of times they may be dealing with something that they're not realizing is affecting them. And it also aids in their personal growth and development and allows for barrier identification and also the process to resolve those barriers, so to seek out solutions. And then our therapist does provide individualized or family-based counseling, dependent on the need, and it's provided for adults, children, and also as a family. And it also helps build what we've seen is positive self-esteem, so they start to feel better about themselves and their situations. Family relationships have improved, and we've also seen them take a better understanding of the importance of their mental health. And during the pandemic, some of the mental health challenges that we've seen caused by the pandemic are anxiety, isolation, depression, suicide ideation, self-harm, DV and couples conflict, parenting anxiety caused by lack of socialization, and people just generally shutting down. So if we can move to the next slide. Program standpoint, we contract with a licensed professional who provides these services to best meet our participants' needs. We offer it through our program at all sites, at the client's home or the therapist's practice to meet the specific client's comfortability. And then it helps us build trust between the program staff and clients, and just to help them better understand that we're here to help. And we're really trying to help them resolve all the barriers that they're facing. And we do that through a holistic approach, so participants can find a better pathway to self-sufficiency. And then ultimately it creates a bridge between a participant's mental health and their self-sufficiency pathway. And it also, again, just helps identify barriers. And that's all I have, but I did send my our family therapist, I sent her information into OFA, so if you guys are needing any help with your own programs and incorporating it. She's open to consulting, and her name is Dr. Bergen, and the name of her practice is Dr. Bergen Family Counseling Services. So if anybody's interested, feel free to contact me. I can send you her contact information, or you can also get it from the resource information for this webinar. That's all I have. Thank you.
Thank you, Maria. That's
You're
great.
welcome. That was a mouthful.
So many questions coming in that, we're always thinking, well, should we put some questions together just in case we don't have any? And yeah, that doesn't seem to be a problem with a lot of topics, but especially this one. So thank you so much. And I'm going to pass this along to our next presenter. Arnold, do you want to go ahead?
Absolutely. So just want to say good afternoon, everybody, from New Mexico, the land of enchantment. My name is Arnold Tiveros. I'm with the Work and Family Support Bureau within the New Mexico Human Services Department. Today, I will be discussing New Mexico's shift to implementing the whole family approach and why this approach was kind of an idea to better serve the citizens of New Mexico. So can we go to the next slide? So just a little bit of a background. Human Services Department within New Mexico transforms lives. Working with our partners, we design and deliver innovative, high-quality health and human services that improve the security and promote independence for New Mexicans in their communities. 4 goals that we have is we help New Mexicans. We communicate effectively, we make access easier, and most importantly, we support each other. Can we go to the next slide? So New Mexico's vision is to work as one team centered around excellence and innovation, devoted to passionately serving and empowering New Mexicans to better their lives. We are committed to our customers, we cultivate our culture, we invest in our people, and we have to be innovative in our systems. Can we go to the next slide? So before we start, on behalf of all the colleagues at the Human Services Department, we humbly acknowledge we are on the unceded ancestry lands of the original peoples of the Apache, Dene, and Pueblo, past, present, and future. With gratitude, we pay our respects to the land, the people, and the communities that contribute to what is known as the state of New Mexico. Can we go to the next slide? So who do we serve? There's approximately 2.1 million people in New Mexico. We serve 1 million unique customers yearly. We have seen an increase of applications for public health emergencies and services. We are committed to meeting the customer's expectation by enhancing technology and expand our call centers to help them access these resources. So I wanted to give you guys that little bit of information so you can get an idea of how many citizens we serve here in New Mexico. Can we go to the next slide? So some statistics before we get started in talking about the whole family approach. Looking at these statistics and why we made this shift is adults in New Mexico without college degree is 2 in 3. Working families in New Mexico that are low income is 2 in 5. Which is the most important statistic is children in New Mexico living with working families that are low income. So with that mindset, going to the next slide, we're going to talk about the poverty cycle. We know that growing up in poverty continues that poverty cycle, little to no access to education and skills, difficult finding employment, remaining within the poverty cycle, and then family in the poverty area. So with this mindset, we wanted to change that. We wanted to do things very differently, having that fixed mindset and really challenging the citizens of New Mexico to think differently, that they have something that they can contribute and that we're delivering today to invest for tomorrow. So we came up with this idea of a better strategic approach And I'm going to talk a little bit about the 3 phases that New Mexico currently is, to talk about how we started the idea, where we're currently at, and how we're going to go forward, and how we are planning to make this as a culture shift. If you can go to the next slide. So you have to trust the process. Shifting from the idea of case management, what does that consist of? Okay, so right now we are in phase 2, but we had this idea. We had to shift. Just like the pandemic had changed everybody's lives, the traditional way of case management had to be shifted. So we had to trust this idea of a more strategic approach to better serve the citizens of New Mexico. Going on to the next slide. So with that being said, we had the whole family approach. That is our strategic model that we hold on to. How do we achieve this model? Is we have 3 best practices. Effective case management. What is effective case management? One of the biggest mindsets is when you're shifting from case management services, meeting the participant where they're at. And that cannot just be physically, it has to be mentally. So shifting that mindset and looking how the correlation to the whole family approach is sometimes not having sustainable housing is maybe the most important thing right now. So shifting that mindset of saying, where is the family at? And we all know that a family all has contributors to the success. So rather than just serving the participant, we served everybody that's involved in the household. So effective case management has been shifted to have more consistent contact and develop more success and build that confidence where they believe that tomorrow is going to be a good day. And no matter whatever situation that they're enduring currently, that they have that support. The one and done principle. That means if we're able to maintain contact with that participant, is to give them all the resources as necessary, to making sure that they are being engaged, making sure that we are prepared when we're meeting with that participant. Last thing is coaching and mentoring. Sometimes when participants do come into those doors, they believe that they're at last hope. And sometimes just a little bit of an encouragement can go a long way. And we've all experienced some type of adversity in our lives that we just needed that one person to really just say, you can do it. And sometimes that person may not be within the household. So our career development specialists really changed the way that they coach the family, really looking at how utilizing what strengths does a family have and how they can achieve their goal. And it's not necessarily the goal of the participant, it's the goal of the family. Really connecting them to other agencies, really navigating them to have more confidence, and really setting achievable goals where they are feeling good about themselves. The system does work. Really trying to change how we look at our case management model and really hone in on pulling out that confidence within the family and saying, does not matter how you got here, it's where you're going. So if we can go to the next slide. So right now, the Work and Family Support Bureau is implementing this whole family approach. We're really connecting our participants to more partners. How do we do that? One of the biggest challenges that we see on a consistent basis is we get a phone number and we give them a phone number and say contact them and hope that they contact them. Well, we're really kind of bridging that gap. So there is a real warm handoff where there is some type of cross-case management where both parties are essentially trying to work together to save the better good of the participant. Sometimes we are not the one-all be-all. Your partner and that partnering agency can provide that cross-case management to really catapult that participant's confidence and get them to where they're self-sufficient. So I want to turn it over to one of my counterparts, Melissa Montano. She's going to talk a little bit about how we partner and how we kind of work together and how we bridge the gap in services here in New Mexico and really kind of take it to that next level. So if you want to go to the next slide, and I'll turn it over to you.
Thank you, Arnold. Buenas tardes, everyone. Good afternoon. My name is Melissa Montano. I'm the Office of Peer Recovery and Engagement Program Manager. And what a beautiful morning it's been. So at the Office of Peer Recovery and Engagement, through the Behavioral Health Services Division, we are really excited about the invitation from the Income Support Division to collaborate in providing integrative services through the whole family approach. We believe this collaboration with work and the Family Support Bureau that it'll advance three mutual objectives. First, supporting agency collaboration and family action. Our agencies will work together to help offer important resources to TANF participants. We'll collaborate in the development of a broad referral process to eligible TANF participants who are facing issues around mental health and or substance use and in the need of specialty services. Second, supporting success, OPRI will make available specialized training to help TANF participants who meet eligibility criteria transform portions of their lived experience into professional skills. They can pave the way, to employability and fruitful careers. At the Office of Peer Recovery and Engagement, our training program was originally created to increase the behavioral health peer workforce. Right now, we have 700 certified peers in the state of New Mexico. Certified peers actively contribute in different professional settings, providing formalized peer support and practical assistance to people who have or are receiving services to manage their own unique recovery process. We meet them where they're at. This credential allows for a New Mexico billable service, and provider agencies are eager to employ us paraprofessionals. Third, supporting empowerment. Over time, this is my favorite, PHSD and ISD envision the creation and development of a platform where CPSWs may be readily available to TANF participants who visit ISD offices and in need of assistance because of a mental health and or substance crisis. Behavioral health challenges, substance use, trauma, mental illness, it's a reality. It's a reality for thousands of New Mexicans from all ages, ethnic backgrounds, and economic and social classes. Recovery benefits everyone. And is a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. Instituting ready access to certified peer support accords dignity to people with lived experience, and it recognizes that New Mexico CPSW and the workforce is a very important component in saving the lives of our fellow New Mexicans. I thank you for this opportunity and to talk a little bit about OPRI and our collaboration, Arnold. Muchísimas gracias.
Thank you, Melissa. If we can go to the next slide. As you can see, we had three different phases. We had this idea of really shifting of how we're doing things. We had success. We saw that participants were more engaged with consistent contact. They wanted more information. They started to have more success. And it just started with an idea, which we phased into going into phase number 2, where we're now implementing it. We are now Team TANF. We've always been Team TANF, but now we have this strategic approach with our best practices, and that's how we're having more success. Where we plan to go is, I want to say that we're in between phase 2 and phase 3, where that's the culture and expectations for any participant or any citizen of New Mexico walking into those doors, is they are going to receive this type of services because we are delivering today. We're investing tomorrow. And as we know, case management, you have to have an open mind because not every participant is the same. I want to thank you guys for your attention and allowing us to speak about what New Mexico is doing. We believe that we're on track. We love our citizens in New Mexico, and we are trusting our processes. And if you guys have any questions or would like to reach out to Militia or myself, our contact information is going to be available for you guys. So thank you.
Thank you, Arnold and Militia. That was great. Just so thankful for your information and how heartening it is to see people moving forward with different ideas. Makes me think about whether or not, all of the ways that we connect with TANF participants are the best ways sometimes, but definitely connecting more often seems to be helpful. Thank you again, and I will hand it over to you, Lisa. Thank you.
Good afternoon. Thank you, Mary. Wow. Well, first, I just want to say that I'm really grateful to be a part of this learning community. I'm learning so much from our fellow presenters as I'm thinking about sharing what we are doing here in Ramsey County, Minnesota, around a program called Families Achieving Success Today. My name is Lisa Getsko, and I am the Integrated Programs Manager at Ramsey County, and I have been a part of the FAST program since its inception, previously working in the partner agency, lead coordinating agency, and now with Ramsey County. Next slide. So Families Achieving Success Today, which I'll call FAST for the rest of this presentation, is a full family participant-driven program and builds on the strength and resiliency that we believe families already have. We believe that every person is capable and deserves to participate in the world of work. And our service approach is always grounded in the respect and dignity of each family who seeks our services. So our program model is an investment in the integration of services, intensive case management, adult and children's mental health, physical health navigation, supported employment, and culturally responsive services to help families reach their goals. Next slide. Our model has but it feels like we've won. We've been recognized both locally and nationally because we are the first program in the country to integrate the evidence-based supported employment program called IPS into TANF service delivery. So we administer it here as a county entity. Our local TANF program, which you'll hear me reference throughout the rest of this presentation, is called Minnesota Family Investment Program, MFIP. And we have a state-funded portion of MFIP called Family Stabilization Services, which you'll hear me call FSS during this presentation. And as mentioned, we have a lead agency of this program. They are Goodwill Easterfield, Minnesota. And they lead the project coordination and service delivery, as well as they are the IPS provider. Next slide. So we use what's called a multidisciplinary approach to serving families. These are all of the coordinated and integrated and co-located partners that are a part of FAST. So our FSS coordinators, which would be considered the TANF case managers, are from our Ramsey County Workforce Solutions team. Goodwill Easterfield, Minnesota provides the supported employment service called Employment and Placement and Support. And then the adult mental health and children's mental health services are provided by Minnesota Care Partner, as well as our county children's mental health for children's mental health services. We also have an organization called Minnesota Community Care that helps provide health and housing navigation. And then we also have a cultural consultant, as well as consulting on education and youth programming, Mary Kay Boyd from MKB and Associates. Next slide. I want to give just a little context around the beginnings of FAST. This started in 2010, where there was a desire to improve the health and financial circumstances for the families we serve. We saw a great need to increase access and coordination, and we were selected to be a part of a pilot study for the TANF and SSI Disability Transition Project. Next slide. From that study, there were positive results, which allowed us to secure funds from the Minnesota Department of Human Services for an additional 3-year local study. We also received additional funding from a racial disparity reduction grant. And today, FAST continues as a permanent, regular, ongoing program through Ramsey County, through that program that I called Family Stabilization Services. Next slide. Real briefly, the early learnings and impact when we began FAST in 2010 was that the program was well delivered, had a very high level of collaboration across the multidisciplinary approach. There was an increase in participants' wages in the first year. It was shown that we could take the supported employment model of IPS and adapt it into a TANF program. And it was suggested that the model could be replicated and evaluated in other locations. However, it's very important to recognize that adaptations to local conditions would have to be considered. Next slide. So who is eligible for FAST? I mentioned the Family Stabilization Services. Very broadly, most of the participants that we serve are experiencing either adult or children's mental health service needs. Next slide. So IPS, the Evidence-Based Supported Employment Program I've mentioned, is a model for people living with mental health conditions to integrate employment as a part of mental health recovery. The focus of employment has been shown to improve self-esteem, increase social and quality of life, reduce substance abuse, better control of mental health services, among other indications. While IPS is intended to be integrated into a vocational rehabilitation model, we use TANF instead of vocational rehabilitation. Next slide. One of the things that makes IPS very successful, and it is based on a fidelity scaled model as well, is commitment to some core principles. And that is that eligibility is based on individual choice. It's not waiting on a result of an assessment. It's not waiting on specific eligibility requirements. It is an inclusionary approach to helping people with employment. Supported employment is closely integrated with mental health and IPS. Competitive employment is always the goal, along with other core principles that you can see listed here. Next slide. So when we take family stabilization services and coordinate that in FAST, I wanted to share that the model has to be balanced and scaled. So we have the capacity to serve about 300 families at any individual given point in time. We receive our referrals from all of the providers that are funded in Ramsey County, and referral is a choice. So while there are mandatory requirements to participate in a TANF program, being a part of FAST is a choice. And the rest of the FAST program contains components that are wraparound tangible services, case consultation, which is a big piece around real-time coordination with all of the FAST partners, which I'll talk a little bit more in just a moment, employment services coordination, and ensuring that there's ongoing connections to all other community resources, whether it be life supports, housing, childcare, and all of the other case management components. Next question, next slide. So the key components of FAST and what makes the support successful for families is having what we see here as more of a roadmap and an ongoing linkage to the services that the family not only may need, but wants. Again, a core component of all of this is choice. We utilize a strengths-based approach. Again, the model of IPS is evidence-based. We utilize motivational interviewing as a core service delivery component. And we're focused on tapping into families' motivation, ability, and opportunities for change to support them along their goal path. Another key component is around reducing competing demands across disciplines. An example of that would be when someone is experiencing an intensity in crisis, mental health concerns and needs, often that therapeutic relationship may make recommendations that aren't the same as a vocational coordinator's recommendation. By having these teams integrated together, we're able to reduce differing plans and differing recommendations. We focus on personal choice, advocacy, and guidance continuously, following where the participant and family is at. We're also able to have lower TANF caseloads in this model so that we can provide deeper engagement and meaningful coordination across the service partners. We also ensure that we celebrate families by bringing them together. We have things called family fun nights, conversation groups, plus groups, which is a support group across moms and therapists, and more. Next slide, please. The other underpinning of FAST is what we call true integration, which means we are not making referrals to a separate agency waiting on a separate process to connect people to mental health services. Our partners are co-located. There's weekly coordination across the teams. And most importantly, there's a shared philosophy and values of serving families. This was a challenge in the early beginnings of FAST. It wasn't that the core partners had competing philosophies, but it was that the approach and the philosophy of when and how to support a family wasn't always the same. We took a significant amount of time to ensure that that was strengthened, and we have seen positive results in how the organizations work together as a result. We have monthly supervisor operation meetings, bringing together all of the leadership within the partnership. And again, we serve full family, not just the parents, but we provide children's mental health case management and coordination, whether it be social, recreational, health, wellness, education, etc., to also support the children so that we can better stabilize families so parents can go to work. Next slide. I have here what I listed as current indicators. These are actually through 2019. I do not have any current indicators up through today's date. But as of 2018, FAST enrollees were more likely to be employed. They were more likely to actively engage in social services. They were more likely to be actively looking for employment. And they were also more likely to be enrolled in education opportunities. Next slide. Lastly, we center the family as much as we can throughout the service model. The family drives the service plan, and the family sets their goals. We are there to support. If I could, I would share many, many success stories with you. I have one here today, just simply pointing out that with the right level of support and integration of services, mom can go from not really knowing how to begin and how to start in the world of work, stabilizing her family, to getting a job that she not only likes, but can support herself and her children on her own. And her quote is, "Don't let anyone tell you that you can't do something. Believe in yourself." Next slide. And that's what I have. I've shared my contact information for you all, as well as my colleague, Michelle Bellitz. Michelle is a planning manager that works with the collaborative organizations within the FAST program. So I wanted you to be able to have her information as well. Thank you.
Thank you, Lisa. Great stuff going on in Ramsey County. So we're going to move into some information about Peer TA and then move into some Q&A.
Thank you, Mary. And before I talk a little bit about Peer TA, I just want to say thank you to our marvelous speakers today. I mean, I certainly have learned a lot, and I really think that there's some really excellent information out there. So I thank you for sharing that with us, everyone. For those of you who don't know, the Peer TA network has a resource library. And if you see on the slide in the upper left-hand corner, the PeerTA library is found at peerta.acf.hhs.gov. And if you go to that, you'll be on the home page for the PeerTA network. And then you'll see some buckets of information, of which resource library is one of them. I'll tell you a little bit more about resource library and how to search, but just as a heads up for everyone, the resource library is updated on an ongoing basis, so it's not like it's stayed in place. And one of the things that we will be putting in the resource library when they're available are today's slides. So I know that some of you have been asking about it, and so you'll be able to find that information more readily. Next slide, please. Now, the resource library, as I said, is this repository. It has a number of different briefs and reports and toolkits, as well as also studies and evaluations and data. And those things are, found in different ways. One way, and I'm not going to go into depth about it, but one way is if you want to filter it by different filters on the left-hand side, where you can actually look by a topic or by a particular state, or some other ways you want to look at it that's important to you. But another way, and probably what's more useful today, is if you want to go into the search box, which is in that corner over here, and in that search box, you can put in a term. And for the sake of argument for today, I put in mental health and families. And what you'll see is that there are about 34, and we'll go to that in a minute, about 34 different resources that are available that have been posted since January of 2020. And basically, the resource library, gives you this different set of cataloging of all these things that you can find if you want more information. There is an archive in the brown box, which will go before 2020, and it goes to the beginning of the PeerTA network in 96. Next slide, please. In that last slide, you'll see, in that pool of 34 resources, this is just a sampling of what's out there. You'll see that we have some data, we have some information out there with, different types of briefs. And again, if you're looking for the resource library, it can be found at peerta.acf.hhs.gov. And basically, as I said, this is a really great tool if you want to learn more information about what's out there on today's topic or on other topics that might be of interest to you. Thank you. I'll turn it over to Mary.
Thank you, Brian. I love PeerTA. I love all the resources. They're great. So hopefully you'll have a chance to, log in and check out what's there if you haven't been there already. And if you have, see what's updated. I'm sure there's some really good new stuff as well. So anyway, we're going to move into some Q&A. And if you have a question, you can go ahead and submit it in the area that James talked about earlier in the webinar, the Q&A icon. I don't know where it is on your screen, but probably at the bottom. And we will start with one of the first questions that we received for Mary Beth. So it's interesting that compared to the general population, staff that assist TANF participant score is high compared to the general, sorry, I lost my place here, the general population. Does this indicate that they are under the same pressures as TANF participants? And if so, how does management address this issue?
That's a great question. Thank you so much. I think just like with the TANF participants, we're not looking at a situation where we know something specific about the staff, but I think being alert to the fact that when someone has a trauma history themselves, they're more susceptible to being triggered when experiencing other people's trauma or their mental health issues. So Ensuring resources for staff, encouraging self-care, and looking out for secondary trauma among your staff is something that is really helpful in keeping them strong and able to do their jobs the best they can.
Great. And I think, Maria, you may have answered some of these questions that came from individuals in the Q&A, but I thought maybe I'd just ask them again so everyone has the benefit of maybe the answers. Is the mental health assessment mandatory or voluntary?
Hello, everyone. We try to make it mandatory for all cash aid clients. For everyone else, it's voluntary.
And how many customers are served in the program?
Anywhere from 100 to 200 at any given time. It fluctuates.
And then a question about how the therapist is funded through Medicaid or TANF funds.
It's funded through our TANF grant. And then when a participant is getting close to transitioning off of our program or getting off our program, she'll work with them to accept their whatever insurance it is that they have. If it's Medi-Cal or if they've started working, whatever insurance is available to them, she'll generally work with them to accept that.
Great. There is, some questions that came through in the chat that I wanted to address real quick, and then we can move on to some others that just came in. Damon, I think some of these are really good, things to think about. One of them is related, I think, to your question or your presentation, Mary Beth, about is there sufficient evidence that poverty is a disease that affects people, altering their ability to achieve the daily activities and maintain personal responsibility?
I'm not sure if I fully understood the question. I don't know that I would talk about poverty as a disease. I think that, as I said, mental health can lead to poverty, and poverty can be a strain on mental health. When we're talking about things that happen to folks in childhood, the fact that it affects their brain and their bodies to the point where those can be challenges to engaging in adult activities, including work, can make that idea that personal responsibility has to also be balanced with somebody's capacity. And if there's skills and things that they need to learn as an adult to be able to be active in the work world and do the things like get to work on time, sometimes those are skills that we actually have to be part of helping them develop versus assuming that everyone comes to adulthood with the same toolbox.
Great. Thank you, Mary Beth. Another question about how these services are paid for. Do most of these programs use Medicaid to pay for mental health services? It's my understanding that TANF cannot pay for therapeutic mental health services.
Hi, Mary. I can respond to that for FAST in Minnesota. TANF is not paying for the direct therapeutic or targeted case management services. It pays for the coordination of the partnership and collaboration. So regular billing practices through those entities occur.
Great. Just moving around here, trying to are there other questions that people want to pose through the Q&A? And I'll just chime in with, another question is whether or not there's practical real-world examples of tools and resources for frontline staff that are not trained in social or psychological services, even not likely to be a social worker. What types of tools and resources are out there in your programs that they tap into. And that could be it for any of you.
I'll just take a stab at it. When we've presented that information that I did to our Department of Workforce Services, one of the very simple things, it's not really a tool, but it's just the idea that when somebody is not able to do something, instead of assuming that they're kind of just choosing to be lazy, getting curious about what's behind that. And one of the examples another presenter gave about the warm handoff with a telephone call, some folks with PTSD have a really hard time talking on the phone. And so giving them a phone number and just assuming that they're going to call isn't going to work. But asking somebody and saying, would you like me to be part of that telephone call with you to kind of help you do that, whatever it is, can be the first step in helping teach them how to engage in those activities that they're just hard for them.
I kind of want to chime in on that. Because I was discussing the warm handoff. One of the biggest things, as I mentioned, is meeting the participant where they're at. I mean, that is really kind of getting on their level, because sometimes we think about, oh, they need to be right here, but they're not at that level yet. And really kind of assessing the situation and navigating them to say, let's take those steps to get to that level, really can determine the success for that participant. And that's where that shift needs to happen is, I know we want to get here, but let's what's reasonable right now? Where are we starting at? And just like Mary Beth was saying, is there's maybe some PTSD about phone calls, and we understand that there's a wait times and people's frustrations, and sometimes people don't have that patience because, again, whatever their situation is happening right now is really overwhelming them. So really kind of coaching them to that, let's get to where we need to be.
Lisa or Maria, do you have any?
Yeah, I think what I'll add is that we do coordination with as many ancillary support services as possible, whether it be connecting with early childhood education, public health nursing, and other services that aren't embedded within our model. And sometimes, using that warm handoff approach works well, but there's often a disconnect sometimes in making that service connection. And so for the FAST program to have that true deep integration, at least with the adult mental health, children's mental health, case management, and supported employment practice model, we're able to all share and consult with each other across our disciplines to best meet the needs, and then try to connect with those other resources as best as possible.
Maria, do you have anything to add?
Just going back to that earlier comment about not being able to use TANF funds for mental health counseling, you can if you build it into your program. So for us, Tribal TANF, we have the flexibility to build these types of services into our program. And as I mentioned in our PowerPoint presentation, is that it's just like a wraparound service. So it's counseling, it's parenting classes, group therapy sessions, and it's aimed at barrier removal for the families. So you can get creative in your programs. It's just making sure that you're incorporating all of that into your plan.
Right.
That's all I have to say.
Important stuff there for sure. Arnold, I just want to go back to what you said about meeting the TANF customer where they're at. We hear that all the time. Like, let's meet them where they're at. But like operationally, how do you do that? How do your staff do that?
I think really just kind of having that one-on-one conversation, really how you're assessing them. Because again, one of the things that our customer has that's frustrating is they have to tell the story consistently, right? And what kind of plan are they built on? And it goes back to the whole family approach. What's the family goal? Really properly assessing the family, you know, using screening tools to really kind of determine where they're at. For example, if an individual has experienced domestic violence, I know, and my staff have been trained, where there needs to be more frequent contact, because again, there's that situation. So again, does that participant need to find employment, or do they need to get, you know, their mental health services in order? And what is the situation at home? So again, it's really just how we're assessing and utilizing our screening tools to determine where we're headed. And again, you know, one of the things is we've all taken an Uber, right? Sometimes you're riding and you trust that person, right? And you got GPS, you're good. And sometimes if you're in a hurry, say, hey, take this shortcut. I mean, we've been in those different situations. And so that's where the coaching and mentoring really come into play, is sometimes that little bit of coaching to help that confidence really kind of drives where they need to go, and meeting them where they're at and really saying, okay, I know where you want to go, but do we need to go there right now? And I think that's really kind of connecting on their level, build that rapport where they have that trust in you. And again, it's very challenging. We utilize our partners and allow our partners to do what they do best at times, you know? And then that's really how it is. You know, it really takes a community to support somebody that is facing adversity.
That's true. I love that analogy. I'm usually in the back of the Uber, like looking on my phone to see if they're going the right way. I mean, it is a trust thing, right? Sometimes you trust, sometimes you're like, I don't know if maybe I need to have a different route, things like that. So I love that. Does anybody else have anything to offer related to that question? Then I'll move into a couple others. We have about, I don't know, maybe 5 minutes left or so, it looks like.
Mary, can I just ask a quick clarifying question for our jurisdictions?
Oh yeah, Damon, go ahead.
We know that all the states, tribes, and territories have different sizes and everything. And I noticed there was one question in the Q&A about what was the caseload size and how many people were participating in the mental health services. Can you give us a sense of how large that engagement is, about how many people you're servicing each year or each week or each month or what have you, thinking about that there may be jurisdictions where TANF workers have 1, 2, 3, 400 cases per caseworker, and having those discussions may take time that physically are not possible given the structure of the program and the size of the caseload. So I know that person in the Q&A was wondering what number are we looking at with regard to providing these comprehensive sets of services. Any other jurisdictions?
So the FAST program, the TANF case managers have caseloads up to 60.
That would be about the same that our staff actually have here, working with the limited population. So it is around 60 to 70.
For Saboba Tribal TANF, we're a smaller program, so our caseload would be per caseworker would be about 30 to 40.
Mary Beth, do you have any ideas about what Utah's at?
It changes so much with actually the staffing and the burnout in the staffing. I think that they're closer now to 30 to 40.
Okay. All
And I'll
right.
quickly add for FAST too, our program isn't able to meet the need in the entire county. We have capacity to serve about 300 family stabilization families at any given point in time. So it still doesn't meet the need for all of the families in our county.
Okay. Great. Thank you. A couple other questions I wanted to try to get in before the end of our time together. How are you all tracking impact with these programs that are in place? In other words, is there a way to track mental health outcomes without pre or post tests that you've used? Or is there maybe another way that you kind of, look at that employment, retention, employment, anything else that you're looking at currently?
So for FAST, because we've been a part of both a randomized controlled study, also through local evaluation, we've been able to track that through the research entities. Our original pilot program was evaluated based on what we call a single intervention, meaning we weren't separating out each of the outcomes and each of the multidisciplinary partners, but rather the outcomes as a whole. So it was a comparative study of families in FAST or families that are in family stabilization services not in FAST. We did not track the separate outcomes of children's mental health, adult mental health, etc. However, we do track engagements and the number of families that engage in each of the services offered, and then the traditional self-sufficiency outcomes as well.
Thank you, Lisa. Anyone else?
How we would track it in New Mexico is based on what Lisa was saying, is the engagement, really kind of measuring the successful contacts. If you are engaging with the participant on a consistent basis and knowing that coaching and mentoring is occurring, and if they are maintaining compliance with their TANF, is also really kind of determining how successful a program really is. Because if they tend to not be in compliance with their TANF, then that means that they're not engaged, and maybe you have to kind of analyze of the direction you're headed. So really it's measuring on the amount and frequency of the contact and how successful you are with that participant. And we also do follow up on the referrals and those warm handoffs.
Great. Any insights on how to balance TANF compliance with client needs? The question of the day, right before we're ready to jump off.
The hardest question at the very end, right? Maintain that compliance and the client needs, it goes back to meeting the participant where they're at, and how you are analyzing them. If they don't have the resources or the capabilities to do a certain activity, do they need to be in that activity? Again, they are giving you the tools when you are meeting with them and said, this is the situation I'm occurring. How can you assist me? And again, it's meeting them where they're at, whether if it's more convenient to meet with them over phone because they don't have transportation, or where they're at mentally. And I think that's really where we try to combat that, ensuring that they are in compliance. And it is a challenge. Again, it's something that we all face. And one month they're doing really well, and the next month they have some challenges. And our participants face adversity on a consistent basis. So again, you have to have an open mind and not be married to one particular idea. And I think sometimes when we hear case management, we're just married to that idea. And really, in order to be successful, you have to have some flexibility and an open mind.
Yeah, for sure. Yeah, Ryan in the chat says that's easier said than done. Really We're out of time and probably went over a little bit. Sorry about that. I'm going to hand it back over to James to close us out.
Thank you, Mary, and thanks everyone. Just as a quick reminder, recording of today's webinar will be available within a few weeks on our OFA PRTA website, and you'll see the link before you on the screen. As Brian already mentioned, our PRTA website offers access to information on programs and policies covering topics including human services, child welfare, workforce development, family strengthening, asset building, and a few other things. So you can also sign up for newsletters and register on our for webinars, any requested technical assistance that you'd like. You can ask questions of your peers, or you can find some professional development opportunities. You can also help us expand our network and reach a greater number of people by directing any of your colleagues to our OFA PRT website. Of course, we'd also like to hear from you about any future webinar topics that you'd like to hear about. And you can see that website before you at PRTA@blhtech.com. Thanks again, everyone who participated in today's webinar. And thanks again to all of our presenters. It was a great webinar. As the webinar closes, we will launch a quick survey that we'd like you to complete regarding today's webinar. The survey will appear in a separate pop-up window when the webinar ends. Of course, your feedback is always very important to us, and it helps us to plan future webinars. Thank you for your time today and taking time out of your busy schedules to join us. We look forward to you joining us in future webinars, one coming up next month, and more details on that one to follow. Thanks, everybody. Have a great rest of your day.